Hello and a very warm welcome to all of you. Thank you for joining us and supporting us last month for our 9 glorious year celebration. Welcome to the Doc Plexus Global Diabetes Summit 2022, which is a 3-day clinical discourse organized from 12th to 14th of November to discuss and tackle the largest and the most affecting disease of the world, discussing topics around access to global diabetes care and education. Since you all must be aware that 463 million adults were living with diabetes in 2019, and this number is expected to rise by 578 million by 2030. 1 in 2 adults with diabetes remain undiagnosed, which is a majority, which majorly are type 2 diabetes. So talking about the prevalence of diabetes in India, currently India has 77 million people affected with diabetes, which makes it the second most affected country in the world after China. And the International Diabetes Federation has projected this number to grow to 134 million by 2045. So we can make an assumption about the plethora of issues that the world is facing currently due to diabetes. Hence, Doc Plexus brings to you the Global Diabetes Summit, which was spread across 3 days. For day 1, sessions were conducted to address the diabetes linked to cancer and surgeries for diabetes and treatment. Day 2, we had planned a CME on A to Z of diabetes prevention and management and advances in diabetes. Day 3, today, we will have experts roundtable discussion with renowned international and national panelists on the latest developments in the management of diabetes, along with another panel for addressing the holistic management of diabetes. Now, coming to today's session, today is the day 3 of our Global Diabetes Summit. For this, we have speakers from India, Middle East, and Southeast Asia. This would be a roundtable discussion on diabetes education and management. Now, diabetes management warrants multifactorial behavior and pharmacological treatments to prevent or delay the associated complications and maintain the quality of life. The management includes maintaining optimal blood glucose levels, weight, and address cardiovascular risk factors, comorbidities, and complications. This hence necessitates care delivery in a patient-centric way to enhance engagement in self-care activities. Careful consideration of social determinants of health and the lifestyle choices of people living with diabetes must thus be considered for tailoring patients' treatment and goals and strategy. For this, we have 3 speakers with us today. The first one is Dr. Tan Ming Yeong from Malaysia in Southeast Asia. She's a certified diabetes educator at the International Medical University in Kuala Lumpur. She is a credentialed diabetes educator from Australia and is currently attached to the International Medical University in Kuala Lumpur. With a strong passion for diabetes education, Dr. Tan is one of the pioneer diabetes educators in the country with over 25 years of experience. She has been a reviewer and a task force member for the clinical practice guidelines, which had initiated the development of the Diabetes Education Manual and Forum for Injectable Therapy Guidelines, and has chaired the Melaka Diabetes Association branch, Diabetes Education Consultative section of the Malaysian Diabetes Association, and is also the past president of the Malaysian Diabetes Education Society. Her main contribution to diabetes education in Malaysia is initiating and organizing regular national diabetes education seminars, conferences to provide continuous diabetes education for local and Southeast Asia diabetes educators and healthcare professionals with the aim to raise the standard of diabetes education in the country and globally. Our second speaker for today is Dr. Neeta Deshpande, who is a consultant diabetologist and obesity physician from Belgaum Diabetes Center in India. She is a diabetes and obesity expert who has been in service for patients for more than past 20 years. She is a crusader for lifestyle modification and as a means of preventing and treating non-communicable diseases such as diabetes, pre-diabetes, obesity, and fatty liver disease. She is also an avid researcher and academician, having been active in the research field and published and presented papers at national and international level in prestigious journals and conferences. She has been a strong force in treating many patients to overcome their diabetes and help them get off their medication via her signature lifestyle program, Reversal of Diabetes. It is a pleasure to have you with us here, ma'am. Our next speaker is Dr. Perele Adnam Hajj, who's an endocrinology expert from the Har Al Sheikh Government Hospital in Lebanon. She is an endocrinologist and has been practicing at St. Joseph Hospital in Beirut, Lebanon, and at the military hospital in Sarba, Lebanon since 2011. She has graduated from St. John's Hospital in General and Internal Medicine. She also holds an accord in endocrinology and metabolism accredited to Paris Descartes 2010. She has been a lecturer at the Lebanese University for more than 2 years and a representative for many multinational and national pharmaceutical companies as well. So without further ado, let's begin today's session, which is the day 3 of our rich science-driven discourse. Now, I would like to first invite Dr. Ming Yeong to speak on diabetes self-management education, what works and what doesn't. Since this year's theme is to access the diabetes education, it would be interesting to hear from our international speaker her point of view for the same. Over to you, Dr. Tan.
Good morning, good afternoon, and good night, depending on where you are listening to this talk. I would like to thank Dr. Plexus for the invitation of this talk. The title of my talk is Diabetes Self-Management, Education and Support. What works and what doesn't work? This is a suitable topic for this year World Diabetes Day. For this talk, I would like to cover what is diabetes self-management, education, and support, or in short form, DSMES, which I'll refer throughout my talk. What are the evidences of DSMES? What are the characteristics of effective DSMES, and what hinders them? The American Diabetes Association and the European Association for the Study of Diabetes has updated their consensus report for the management of hyperglycemia for type 2 diabetes this year. This is a very recent publication. And in this consensus, it stated that diabetes self-management, education, and support is a key intervention as important to the treatment plan as a selection of pharmacotherapy. So what is this diabetes self-management, education, and support? For those who may not be familiar, let me just elaborate a little bit. At the root of diabetes care, it is the people with diabetes or their caregivers, because they don't live alone, to take care, to understand their role in the management of diabetes by acquiring the knowledge, the skill, and be motivated to be their own active self-manager. So how do they achieve that? We healthcare providers, we collaborate with them by facilitating these people with diabetes and their caregivers with the knowledge and skills of AADE 7 self-care behavior, which are healthy eating, being active, monitoring, taking medication, problem solving, healthy coping, and reducing risk. I will further elaborate this AADE 7 self-care in my following slide. If people with diabetes and their caregiver can acquire this and willing to acquire this, then they can develop their personal goal and action plan. Living with diabetes is not a smooth journey. They have to learn to cope with the emotion and life stresses of living with diabetes through problem solving. Then they can make the informed decision for themselves and successfully self-manage the disease and its related conditions. In the American Association of Diabetes Educators, in 2003, they came out with a position statement of this AADE 7-cell care after much research. Because people with diabetes will need to know the knowledge and skill of healthy eating. We need to be active. We need to monitor themselves regularly and take the medication as per prescribed by you doctors. By doing this, then only they can reduce the risk of developing acute and chronic complications. As mentioned earlier, living diabetes is not a smooth journey. So they got to learn about problem solving, such as when they have hypoglycemia, hyperglycemia, and sick day. As all of us know, living diabetes can be stressful. And it is already shown in a lot of research that people with diabetes have higher anxiety and depression. So we got to facilitate them in healthy coping. This AAD 7-cell care is essential and effective for successful diabetes self-management in the life of people with diabetes. And this framework of AAD 7-cell care is actually provide us with a new paradigm shift in diabetes education approach, which you can use in clinical care, education program, and population study. Second, we need to know how effective is this DSMES, and is the efficacy of DSMES sustainable? Sharon Brown, who is a professor of nursing in the 1980s, she published 3 systematic review and meta-analysis to assess the effectiveness of DSMES. Through her publication, it is shown, yes, DSMES can improve knowledge and skill, but with minimum change in self-care behavior and clinical outcomes in terms of glycemia. Because at the time, in the 80s, she had included study in the 70s, 60s. The education approach is very much a didactic approach, which is transferring of knowledge. That is content-driven with little use of behavioral science. That is outcome-driven. That is what we need in the change of behavior. After the year 2000, there are emerging publication of DSMES. And this is one of the earlier ones by Susan Norris and her team that demonstrate the efficacy of DSMES on blood glucose control. They've included 31 RCT, and in this meta-analysis is shown DSMES can improve HbA1c by 0.76%. But you need 26.3 contact hours to reduce 1% of HbA1c. However, at this early stage, DSMES is only effective for less than 6 months. Then the latest study by Caro et al. In her systematic review, she has shown, no, DSMES is even effective after 12 months because her publication were later, from 1997 to 2030. And in the same study, they have also shown DSMES is effective in lowering the glycemic control irregardless of the level of glycemic level at baseline. This is a much latest publication that was only published last year. It assess the efficacy of DSMES on glycemic control by HbA1c. Well, again, it reported it can reduce 0.6%, and which is significant. The reason I included this paper is because, if you can follow me here, the efficacy, this paper has included study both from the high economic class, high economic social country, such as America, North America, and Europe, as well as middle socio-economic countries such as Asia, South America, and the lower socio-economic country. And as you can see, all the papers they included, a majority of them have shown it can reduce HbA1c, which is significant. So the conclusion is the efficacy of DSMES intervention is across different socio-economic society. And even before the COVID pandemic, DSMES that uses the mobile phone application has already shown it is effective to reduce HbA1c by almost 0.5%. And this study was used for both type 1 and type 2 diabetes between the age of 34 to 62, and with a long duration of diabetes 5 to 19 years. One of the reasons why mobile phone application can reduce HbA1c is because it enhances the participant in their own self-care, in their own insulin dose adjustment, their advice on dietary intake, their encouragement on physical activity, and their encouragement in doing blood glucose monitoring. So when the pandemic arrived in the year 2020, many of the countries, as well as healthcare providers, are using the mobile health to help the patient continuously, provide them with DSMES to maintain their HbA1c. As we know, people with diabetes are at high risk of COVID-19 infection. So now, to further understand the characteristic of efficacy of DSMES intervention, we have done analysis of 10 meta-analysis and systematic review. From 2002, if you follow my cursor, to 2022. They include both type 1 and type 2 patients, and with more than 50,000 subjects. I would like to draw your attention on the efficacy characteristic. Education contact hours, as you can see, if I go back to the former slide, is about more than 10 hours. Education provider, multidisciplinary education topic, and education intervention and approaches. So my next slide will summarize the characteristic of efficacy of DSMES intervention. There is no one approach that will fit all interventions. You need a combination of it. The mode of delivery, whether it's you provide DSMES to individual, to group using technology, it is all very effective. Intervention provider, it appears that if the multidisciplinary team that consists of the doctor, the diabetes nurse, dietitian, pharmacy, clinical psychologist seems to be more effective rather than just one in healthcare provider. Very important. Intervention contact hours should be more than 10 hours and not just 1 hour, 2 hours of DSMES. It's not going to be effective on that. For education content, most of them has used provide their DSMES based on the AADE 7-cell care. And they have incorporated behavioral science, such as self-efficacy, motivational interviewing, empowerment, because only through that you can get the patient to change the behavior. Another one, very important efficacy characteristic is two-way communication, which is shown in the diagram on the right-hand side, where the patient will generate their healthcare data, such as their blood glucose monitoring result, their home blood pressure monitoring result, body weight, and then they will share this with the healthcare providers like you and me. And then we will provide very prompt feedback with actionable plan and education, then only it will be effective. Now, this two-way communication is not one-off. It should be consistently following the life of the people with diabetes. To further understand the characteristic of DSME efficacy, this systematic review and meta-analysis, they included 22,000 type 2 diabetes with the mean 1 year intervention of DSME. It analyzed now. Remember we said earlier, the healthcare provider is important. Now this paper break up the different healthcare providers' intervention and see how effective is which one. If you can follow my cursor, for the pharmacy-based intervention, they did it through meta-regression, that for pharmacy-based intervention, it can reduce HbA1c by 0.6 to 0.9%. For care management and patient education, this approach of education is just DSME supported by telecommunication or supported by technologies. The third one is the physician-based intervention. It reduced HbA1c by 0.26 to 0.4. The last one is the nurse or CDE-based intervention. It reduced HbA1c by 0.4 to 1.62%. The question now you may ask, why is it the physician-based intervention seems to reduce less glycemic control as compared to the alive health? One of the very possible explanation is we have different roles in the management of diabetes. You as medical practitioner, you look after the medical aspect of diabetes. We in the alive health, we have more time, and it is our role to educate the people with diabetes. And remember, it said the intervention contact hour should be more than 10 hours. As physician, usually you will have limited time spent with them, compared with healthcare providers like us. Even though there are a lot of study done on DSMES, but we still need additional research to identify new effective characteristics for DSMES. One of the things that I can think of, is there a difference in the clinical outcomes of DSMES intervention provided by a credentialed diabetes educator versus non-credentialed diabetes educator? CDE can be a certified diabetes educator too. It all depends on which country you use the CDE. And who is this credentialed diabetes educator? He or she is a healthcare professional who have undergone specialized training in educating, supporting, and promoting self-management of diabetes to the people with diabetes. Another area for research that require further research is education content, who are currently still not very well defined. Because if you look at the studies, some of them just included 1 or 2 AAD self-care. Some they have included all. So which is more effective? Lastly, living with diabetes is a lifelong self-care practices. Is DSME as sustainable? Currently, most of the study, the intervention is between 6 months to about 36 months, 3 years. A few of the papers may have published until 5 years. But people live with diabetes for life. So we may need more research to try to understand whether if we prolong the intervention to 10 years, 20 years, does it make any difference in their life, in their clinical outcome? Now I shift gear to when do we refer to DSMES. This is a consensus report that was just published last year by the 7 Health Professional Association from US. It has identified 4 critical times for diabetes self-management, education, and support services. As you can see in the diagram, at diagnosis, that is very important. Annually, or when the target is not met, or when complication factors develop, such as when a person with diabetes now it requires dialysis or end-stage renal failure, or when a person with diabetes now had a stroke, or when a person had diabetes now they have lower limb amputation. Or the last time is when transition in life and care occurs. That is, when if a child has diabetes, their journey in life is from a child to a teenage to an adult. When an adult has diabetes, if he has a cardiac event, he landed in the hospital on discharge, the needs are different. Or an elderly people with diabetes, they may move from the home to the aged care institution. Because at all these different timing, the needs of diabetes, DSMES, is different. By providing them with DSMES at this critical time will help them in coping up with their new challenges, will help them to maintain, to achieve a better health outcome and quality of life. To understand what hinders DSMES, let me explain the referral process for DSMES. When a person has diabetes in 1, hopefully they go to number 2 healthcare system and meet you as their doctors, whether in the primary care or hospital. When I say hopefully, because we also know some of them are lost along the journey to traditional medicine and other alternative management. Then the medical practitioner like you will refer them to number 3 for DSMES, whether to the diabetes nurse, dietitian, pharmacy. With the intervention of DSMES, we hope to improve the person with diabetes, their clinical outcomes such as HbA1c, blood pressure, and lipid, and so on. If now I put a barrier there in the referral, then the person with diabetes will not reach step 3 and the clinical outcome can be compromised. So issues related to DSME referral or barriers, which can be broadly divided into 3: healthcare providers, people with diabetes, healthcare system, which I'll share with you some of the literature in my following slide. This is a study that was just published last year again. It's a cross-sectional analysis of patients. There is more about near 900 adult type 2 diabetes from Indiana, USA. Their electronic records to estimate the patient's need for DSMES and likelihood of referral for DSMES. And guess what is the result? The papers are published at the same time. This one and the 4 critical times for DSME, which was also published in 2021. So they're based on the recommendation and see how many of the patients are being referred. Newly diagnosed, when the level are off target, when complications factors step in, or when transitional care happen. As you can see, about only 10% will refer for DSMES. Just to support this, we have another paper that was published this year by Neeta et al. They look at the quality of care for type 2 diabetes among the US adults by checking their Medicare insurance, based on their Medicare insurance. As you know, in America, patients are their healthcare system based on Medicare insurance. And only 3.4, when they check the insurance claim, only 3.4% of the claim came from DSMES. Laboratory service is about 60 to 80%. Retina examination is about 33%. So we have a long way to go for the referral. How about from Canada? This paper again was published quite a while ago, but it examined the practices of primary care physician referral to diabetes education and the factors that influence their referral. It has included 91 primary care physicians, about 13% of their medical association members, and only 46% of the primary care physicians refer all their patients for DSMES. Who are the ones they will refer? Those newly diagnosed with type 1 or type 2 diabetes. Those who require insulin, because usually medical doctors, you don't have much time to teach insulin injection. Or those that think they will benefit from education. But if you look further down, patients with gestational diabetes, and all of us know, it is very critical to refer this group of patients for DSMES because it influences the maternal and fetal outcome. But for this group of patients, only 1 in 2 is being referred. Patients with pre-diabetes. As all of us know, pre-diabetes is a very hot topic globally because we want to delay, we hope to stop them from becoming diabetes. Only 1 in 3 are referred. How about in UK? This paper is published about 5 years ago to determine what are the factors that associate with diabetes education attendance among newly diagnosed patients in South London primary care practices. 70% of the GP, they actually agreed to participate, and they were very cooperative in this research because 91% of them actually share their patients' data. And if you look at the result, only 1 in 5 attended diabetes education. The patient that attended these GP practices. There are 2 main reasons why they attend. Patients factor usually are the female, those with better glycemic control and non-smoker. That means those high-risk patients with high HbA1c smoker, they are not attending. And who are the practitioners? They are more likely to refer their patient for this diabetes education. Those practitioners they achieve their primary care target for HbA1c. Perhaps the different practices will have different targets. Some may say, oh, I want my patient to have at least 70% achieve their HbA1c target. This is another report from UK, referral and attendance of DSMES from the NICE, National Institution of Care and Excellence. Impact Diabetes Guideline Report 2018. In this report, it said that 4 out of 10 type 1 were referred but less than 5 attended. 8 out of 10 type 2 were referred and less than 10% attended. However, the author cautioned us in interpreting this result because they also found another UK National Pediatric Diabetes Audit for type 1 and type 2 diabetes. Almost 60 to 70% attended DSMES. So this data could be underreporting. And one of the reasons they mentioned, explained by the author, is because when they enter the data, they use certain code. So it could be entry of the wrong coding. And this is the last one that is from Australia. It's quite an old paper to quantify use of diabetes and life healthcare services in 2 New South Wales rural general services. Only 40% of these patients have consulted a diabetes educator, and 1 in 5 consulted a dietitian. Half of them has consulted podiatrists because New South Wales has been well known for its foot care services. 25 to 40% of these patients had never used any of these services. That means whether have consulted a diabetes educator, podiatrist, or dietitian. One of the reasons for non-utilization is because patients don't think so they need it. And 1/3 of them thought that their general practitioner already provided the similar service. But their general practitioner mean annual visit by this patient is only 5.6. And he also shown that who are the ones that are more likely to use these services are those when the general practitioners have structured planning for the people with diabetes. They are more likely to consult a diabetes educator and podiatrist, and more likely to see the general practitioner more often. When I mean structured plan, that means every year the patient newly diagnosed should visit how many visits, they should be referred for diabetes education, dietitian, and so on. Some of them, they just patient come in and out. There is no structured planning for them. How about in other countries, such as Southeast Asia? There's very little data on this. DSMES reference. And this is the last systematic review by Horrigan that was published in 2017. Very interesting. He analyzed the reason why patients referred to diabetes education program choose not to attend. As mentioned earlier, broadly, there are 3 reasons why the referral was not successful or patient did not attend. One is from healthcare practitioner, if you can recall. Second one is from people with diabetes, and the third one is from healthcare system. From healthcare practitioner, some of them may not perceive it is necessary or the efficacies of DSMES. Maybe due to lack of awareness of such services, limited access to DSMES, or unsure of the guideline of how to refer. Some of them also may be concerned that if I refer the patient to see for DSMES, they may not go, or I may lose my patient. As in my country, we usually do not take walk-in. That means patients just walk in and request DSMES. We require a referral letter from a doctor. And in my country, DSMES services are usually only available in the tertiary institution and some of the big primary care centers. So if in the public centers I meant, whereas there are no DSMES services among the GP group. So if they refer to the private hospital or the public hospital for the DSMES service, they may lose their patient. That's why some of them only refer high-risk patients and not those with stable HbA1c. Or they prefer to manage the patient themselves by providing them with the DSMES. From the people with diabetes aspect, broadly, there are two reasons. If you can look at it, follow my cursor. One is who could not go. The other one who would not go for DSMES. Could not go usually is due to logistic reason because the DSMES timing just does not fit into them because they are working adult. It's only offered during the office hour. Or maybe transportation problem. Usually, for some countries, to attend DSMES is either covered by insurance or you pay out of your pocket. If this consultation is not paid by the insurance, like in my country, patients will have to pay out of their pocket, then they won't come. Medical reasons can be due to physical disability, such as after a stroke or other physical disability or other medical problems. Then the patient could not go for DSMES. For those who would not go, one of the very important that frequently come out answer is they perceive that it will not benefit them because they think that these services is not important because their doctor have not emphasized the importance of it. Another one is they perceive that they already have adequate knowledge for it because I live in a family of diabetes from my grandmother, grandparents, my parents. I know everything about looking after myself. Or they may think that I can source the information from the social platform. Emotional issue, some of the people with diabetes, they may be upset about their diabetes. They may not be able to accept that they have diabetes. Or sometimes they may think that they don't want to know about the complication of diabetes. They may not like to sit in a group education. Cultural, which is very common, the first item that come out is language. Even in my country, providers of DSMES majority are Malay. But the patient is a combination of Malay, Chinese, Indians, and so on. So when the patient cannot understand your explanation of DSMES, they won't go. Literacy and numeracy is also a factor. And in some countries, the female and the elderly are not to attend any of these classes without an accompanied person. And the accompanied person is very frequently not free to attend with them. From the healthcare system, referral can be a challenge because for some countries, because of insurance claim, they have to fill up a lot of form when they refer for DSME. It's just too much. The general practitioner just, I'm not doing it. an appointment system because of limited access to DSME. In some countries, the waiting list for a dietitian appointment can be 4 to 6 months later. DSME programs currently are just too long and inflexible. 1 whole day, 2 days, 3 days, or maybe every fortnightly you need to attend for 6 months. So a lot of patients just say that it's too much for me. So what if we don't offer or encourage our people with diabetes to attend DSMES? Is there an issue? This paper was published a quarter century ago. It's a case control study, multi-center over 6 months with almost 3,000 subjects. They want to know why is it in this different center, some of the patients develop complications and some don't. They're trying to understand that. So through multivariate logistic regression analysis, one of the very interesting findings come out. Patients who did not attend any form of diabetes education intervention had a 4-fold increased risk of developing complications. Another more recent paper, which is a cohort study of type 2 diabetes, to identify the effect of glycemic control from diagnosis to complication, microvascular, macrovascular, and mortality among almost 35,000 subjects from Kaiser Permanent Diabetes Registry in US. And this study is called the Diabetes and Aging Study. It's a very busy slide. Don't worry, just concentrate on the red bone number. And let me take you to it to explain what it all meant. For this subject, they were all at the baseline, they are divided into 4 groups based on their HbA1c. 6.5 to 7%, 7 to 8%, 8 to 9%, and more than 9%. And then, as you can see, even at diagnosis, you are diagnosed early, your HbA1c is only 6.5 to 7%. You're already exposed to diabetes complication. Micro, macro, and mortality. But if the person so choose to follow your medical advice and take active management of themselves after attending DSME, after 7 years, the hazard ratio for the complication, micro, macro, and mortality remains the same. Now we look down. If the person is diagnosed late, when they are diagnosed, their HbA1c is 8 or 9. Obviously, at diagnosis, their micro, macro complication and mortality is higher, as shown here. But if this person so choose to ignore your medical advice, not following your prescription, and choose not to attend DSMES, choose just not to improve and to change their lifestyle. After 7 years here, for those who have more than 9% HbA1c, their macro complication and their mortality is 1.5 times higher than baseline. But their micro complication hazard ratio is 3-4. So prolonged HbA1c with more than 8% increases micro complication, microvascular complication. Early intervention, early intensive treatment with DSMES for newly diagnosed patients is very important to avoid irreversible long-term diabetes complication and mortality. This is I'm coming to the end of my talk. In this slide, I would like to compare efficacy of DSMES versus diabetes medication. This table has shown you the different group of diabetes medication or pharmacotherapy and what is their efficacy of reducing HbA1c. It's about 0.5 here to about 1.5, 1.6, depending on which group of pharmacotherapy you use. However, we need to bear in mind, diabetes medication does not come without cost. It can be expensive, especially for the newer medication like DPP-4, SGLT2, GLP-1. It does not come without side effects. All medication have side effects. By engaging in DSMES services, you all know, we have seen, we have heard, it improved HbA1c by 0.6% without side effect. If we combine the two, would you agree with me? Your patient will do much better. For World Diabetes Day, every year is celebrated on the 14th of November. And the last few years, the theme of World Diabetes Day is shifting gear to diabetes education. In the 2020, the theme of World Diabetes Day is Diabetes Nurses Make the Difference. Last year is access to diabetes care. If not now, when? This year, 2022 is diabetes education to protect tomorrow. So in summary, evidence have consistently shown DSMES improve glycemic control. It should be offered to all the people with diabetes, regardless of their HbA1c level. DSMES service sadly is underutilized globally, which is contributed by complex reasons from the healthcare providers like us, people with diabetes and healthcare system. Too many people are simply just rejecting educational opportunity without you fully understand what is being involved and how they might have gained from attending it. So new and innovating methods of delivering diabetes education are really needed. Currently, most countries trying to improve DSMES services by just focusing on curriculum content and quality assurance. But very little attention is being paid to fit diabetes education to the needs of the people. So we actually have to think out of the box. We have to think of a way to promote DSMES, not as a service, but as a product like a new watch, a new car, and learn how to market it. We know marketing is not our training among the healthcare provider, but this is something we have to learn and then deliver it based on the needs and belief of our clients. There is the people with diabetes, they already told us our program is inflexible. Our referral system is currently not the best, and we may have to change many things. So consider referring your patients with diabetes for DSMES. You benefit everyone. You benefit you. You benefit your patient. You benefit their family, the society, the country, so that we can jointly work as a team to reduce global burdens of diabetes care. With that, I thank you for your attention.
Thank you so much, Dr. Tan, for such a thorough presentation and for participating in Global Diabetes Summit. Dear audience, feel free to start posting questions, which we can take up from our speakers. Next up is Dr. Neeta Deshpande from India, who would be talking about diabetes remission, the new age of treatment. Over to you, Dr. Deshpande.
A very good afternoon to everyone tuned in here. At the outset, I would like to thank Doc Plexus and the Global Diabetes Summit for giving this wonderful opportunity to me to speak on a topic that I've been closely associated with for the last few years. So I'm going to be talking about a very hotly debated, talked about topic, and that is remission of diabetes, which was earlier called reversal of diabetes, but now we prefer the term of remission of diabetes. So let me start by sharing my screen first. Yes, so as I said, I'm going to be talking about remission of diabetes, the different modalities that are there for remission of diabetes. How does it happen? Does it really exist? I'm not really going to be talking about the twin cycle hypothesis and how remission occurs, because that has been talked about a lot, but I want to give some opinions and some takes on what remission means to us today of diabetes. So the core goals of remission, as all of us would know, is weight loss. So weight loss is now considered to be one of the primary goals of treatment of type 2 diabetes, even apart from remission. And it is a hotly debated issue whether it is weight loss that should be the primary target of diabetes treatment, or it should be glycemic control. However, it is important to understand that weight loss is an extremely important goal, if not the primary goal of treatment in type 2 diabetes, because it leads to improved glycemic control. And the most important thing is that fundamentally, when you talk about remission, it is weight loss that drives remission. And then that weight loss could be by any means, which I want to discuss with you, the different modalities of that weight loss, which can lead to remission. Then coming to the definition, what really constitutes remission? What would you say is remission of diabetes? Of course, the exact criteria are still debated. It is important to note here that the term cure has not been applied to type 2 diabetes, and that is the rational thing to do, as there is a potential for reoccurrence, which has been well documented in literature. However, in the ADA 2021 consensus, which has not changed in the 2022 consensus, diabetes remission is defined as a return of A1C to less than 6.5% that occurs spontaneously or as a result of some intervention. That intervention could be anything, which persists for at least 3 months without any glucose-lowering medication. However, there is one concern in this definition because it says no medication. And today we know that drugs such as SGLT2 inhibitors, GLP-1 receptor agonists are prescribed for reasons other than just glycemic control. So if any type 2 diabetes patient goes into remission but is still prescribed these drugs for its other effects such as cardiorenal protection, then what happens to the definition is a question mark. Other than that, excluding metformin from glycemic control medications list also has the same implications because metformin has implications beyond diabetes. The other thing is that the guidelines do recommend metformin even in pre-diabetes. So again, there is this confusion, and I think it's work in progress. And the definition will still evolve. Maybe the 3 months criteria will go away. Maybe the no drug criteria may go away. So we just have to wait and watch for more data to come in to, make this definition more robust. So let's examine the evidence that we have so far as remission is concerned. So we all know that weight loss by any means can drive a type 2 diabetes patient into remission. So primarily, the modalities of weight loss that can actually lead to remission, according to evidence, have been bariatric surgery, low-calorie diets, and to a certain extent, low-carbohydrate diets. So let's examine what this evidence looks like. When you look at bariatric surgery, we know that it has consistently been shown to dramatically improve blood glucose, effectively reversing diabetes up to 80% of patients in the short term in a few series. The most important thing is that we know today that there is a change in the GI hormones, such that feeding behavior is influenced. So it's not entirely driven only by the weight loss. The other thing is that we also know that surgery could cause dramatic changes in the gut microbiota, which we know can be obesogenic, and it can go from obesogenic to a lean bacterial population, and that may be the other way in which bariatric surgery can reverse diabetes. So if you look at the remission rates with bariatric surgery, whether it is complete or partial, you have 5-year studies and you have 10-year studies. In the 5-year studies, you have the sleeve pass and the stampede, which have used sleeve gastrectomy and the Roux-en-Y. It's only in the stampede that it has been compared to an intensive medical lifestyle therapy. And you can see here clearly that medical lifestyle has just given 5% remission rates, whereas it has been 29% with Roux-en-Y in one study, that is the stampede. When you look at the 10-year studies, 10-year remission was 83% in one study, and the SOS study, which is quite famous, the 10-year follow-up has shown 36% remission. So in general, the long-term remission has been seen in 1/3 of the patients. But you must remember here that in the Stampede trial that you have seen here, the medical therapy has not used very low-calorie diets, and I'm going to show you some data about that as well. Now coming to the low-calorie diets, low-calorie and very low-calorie. So that is what you've seen in bariatric surgery, that at the end of 5 years, 10 years, 1/3 of patients still stay in remission. The problem with low-calorie diets is the difficulty with long-term maintenance and micronutrient deficiencies, which happen when you use very restricted diets, and supplementation and monitoring may be required. But that's also true of bariatric surgery. Micronutrient deficiencies are known and supplementation is required. So let's look at the remission rates vis-a-vis what you saw in bariatric surgery. Now, this is the Look Ahead trial, one of the very first trials in 2003 that involved 5,000 patients, and there was intensive lifestyle modification. And the remission rates at 1 year were 11.5, 2 years 9.2, and it dropped to 7.3 at the end of 4 years. And if you recall, I told you in the Stampede trial, it was 5% in the medical treatment arm, so which is very similar to what you got in Look Ahead. Then between 2015 to 2017, there were some more studies that came out, including the Y-weight by Osama Hamdi from Harvard Medical School, and this assessed short-term remission. And the Y-weight trial had only 4.5% remission. It should be recalled here, again, this was not a very low-calorie diet. The diets were typically 1,400 to 1,500 calories, which was just low-calorie, not very low-calorie. And that could explain the reason that it was only a 4.5% remission. Then came the era of very low-calorie diets that were actually spearheaded by Roy Taylor. He began his studies in 2011. And his studies continue. And I'm going to go into a little bit of detail with that, because now we had robust evidence that you could reach remission rates that was somewhere close to that that was given by bariatric surgery. So in 2011, there was an initial 8-week study, a proof of concept, so to speak, which was 600 kilocalories, which was a very low calorie diet. But 25%, though there was remission, 25% had an early recurrence. So a larger, longer study was then carried out in 2016, which was published. And the responders were identified as people who had a fast take of less than 126. It was again 8 weeks. Meal replacements were used, and a 6-month weight maintenance program was also initiated. At 6 months, 40% of the initial responders were still in remission. So this was definitely much better than the 2011 study, because at 6 months, they had a good remission rate. And then came a bigger study, more robust, and that was the DIRECT trial that all of us know about. And this DIRECT remission clinical trial, diabetes remission clinical trial, was actually run in primary general practices, clusters of primary general practices. The inclusion criteria were type 2 diabetes of less than 6 years duration without insulin therapy, and the BMI to be more than 27. So these were obese patients. So they had 306 patients and they were randomized to receive standard care versus a very low calorie diet, which was around 800 calories for 3 to 5 months, which was followed by gradual reintroduction of food. And they were followed up then for 1 year and 2 years, and because of after the stepwise food reintroduction. And then there was a long-term weight maintenance program. And what did they find? They found, of course, the diabetes remission criteria were A1C less than 6.5% with no medication. And what they found was that the remission rate at 1 year was 46%, which is so much more robust than the previous medical studies, which were just around 5 to 7% of remission of diabetes. Here you had 46%. And at 2 years, though it had dropped a little, it was still 36%, which was again similar to what was seen in the bariatric surgery studies. Remember that these were the first series of studies that used a VLCD, a very low calorie diet between 600 to 800 kilocalories. And this was the direct trial. And I can show you here that in the intervention arm, you had a 46% remission rate with an odds ratio, which was very impressive at 19.7. The important thing is in the bottom panel. You can see here that even with a 5 to 10 kg weight loss, there was 33.9% remission. Of course, the highest remission rates were seen in the biggest weight losers. So people who lost more than 15 kg, about 86% of them had remission of diabetes. So it's very, very clear that it is weight loss that drives remission. The average weight loss in the direct trial was around 8 to 10 kgs, 10 kgs actually. So you can see here that remission was effected by a robust, very low calorie diet, and more the weight loss, more the chances of remission, more the chances of staying in remission. Then comes the durability. So that was 1 year data. What happens at 2 years? Does it still persist? So the durability of a primary care-led weight management intervention in the direct trial was again reported, and it showed that there was sustained remissions at 24 months for more than a third of people with type 2 diabetes, and this was linked to the extent of sustained weight loss. You keep the weight off, you stay in remission. That was the clear message. So remission is closely linked to weight loss. 64% of participants in the direct study who lost more than 10 kgs were in remission at 2 years. So it's clearly linked to the weight maintenance. Those who were in remission after 1 year and who had stayed in remission had obviously lost more amount of weight, that is more than 15 kilos, than those who did not stay in remission, who had lost around 12 kilos. So the magic figure was at 15 kilos. So people who lost more than that were more likely to stay in remission, and that was the message from the direct trial. There were other important lessons which are not really talked about much from the direct trial, and that's what I'm going to show you here. And that is, there was loss of ectopic fat with remissions at 24 months. You can see here that the liver fat falls, the VLDL falls, and the pancreatic fat falls. So this is what happened in the responders, and that is how they could stay in remission because of these parameters. And that's the important lesson to be learned from the direct trial about remission. The other very, very important thing that you can see over here is that the blue group, these are the normal people. So what you see at the end of the study in the remission in the direct trial is that the pancreas volume almost came close. This is at 24 months, at 2 years. So the pancreatic volume came very close to those people who were normal. And fortunately, the pancreas raggedness, which actually which happens in type 2 diabetes, which is quite severe, as you can see here at baseline, that comes so close to normal people. So pancreatic raggedness reduces and comes almost close to the normal people. And importantly, the maximum insulin secretion at 24 months of people who responded and remitted comes to almost non-diabetic levels, which is the most encouraging part, which tells you that the beta cells have recovered, the pancreas has become more normal morphologically, and the beta cell capacity has come back almost to normal with the weight loss that has occurred in this particular study. After that, there was a spate of trials, and then this is a comparative analysis of all the interventions reporting type 2 diabetes remissions. This is, of course, the direct trial. I told you that 10 kg was the mean weight loss and 46% at 1 year, and the compared to the usual care of 4%. Then came the diadem study, which happened in Qatar, and here you can see that the average weight loss was 12, and 61% was their rate of remission, which was very, very impressive. Volta Health is basically a keto diet, a VLCD keto diet. The weight loss is more, but the type 2 diabetes remission was a little less. Now you compare this to the Look Ahead trial, which I told you does not really come to the calorie control that happened with the previous trials that I just now talked about. Though they did use meal replacements, the weight loss was 8.6%. This was in kgs and this is in percent, but the remission was 11% as compared to 46 and 61. So clearly, the comparison here is between apples and oranges, because the very low calorie diet approach that has been used clearly shows you that you can get a much better remission rate than just reducing the calories a little bit. So when you reduce calories a little bit, you get a much lesser weight loss. You can have improved glycemic control, but you will not get remission. This is the message that also needs to go out into the public when you're counseling a patient, that smaller weight losses will give good glycemic control, but they will not result in remission. For remission, you require much larger weight losses, because if you want the pancreatic morphology to come back to normal, if you want the beta cell capacity to come back to normal, you need much larger weight losses, because you need the pancreatic fat also to go down. So the summary of evidence with low-calorie diets, effective in short term up to 2 years, as you've seen. Of course, there are ongoing studies for much longer. It is effective predominantly in diabetes duration less than 6 years, as seen in the direct trial. We do not have evidence, that much of evidence for diabetes more than 6 years. But in the Indian scenario, I can tell you that we have our own data which shows that it is effective even in diabetes more than 6 years, sometimes even up to 15 to 20 years. And that is mainly because of our high carbohydrate diets, which when reduced can lead to remission even if the diabetes duration is longer. As I mentioned earlier, substantial level of caloric restriction is required, not just a little, but a lot. Modest weight loss is not effective, as I already mentioned to you. Of course, there's difficulty with long-term maintenance. There is some concern about deleterious effects on body composition and physiology of severe caloric restriction, but there is data to say that that may not also be true or tenable. Micronutrient deficiencies can occur as in bariatric surgery, and supplementation and monitoring is required. Then comes the third modality of treatment about low carbohydrate diet. In the pre-insulin era, it was the mainstay of treatment. And once insulin was discovered, people thought that they could eat a lot of carbohydrate and then chase those sugars. And that's what we still do. We try to chase the sugars. We raise the sugars and then try to chase it. So that is the fundamental behind giving a low carbohydrate diet, that you do not allow the sugar to rise, so there's no question of chasing it. That's the importance of knowing about low carbohydrate diet. So the goal of treatment is to maintain blood sugars with increasing medications versus prevent rise of glucose. So instead of allowing it to rise and increasing medication, do not allow it to rise at all in the first place. That's the fundamental behind the low carbohydrate diet. It is also endorsed by the ADA, EASD as an eating pattern for diabetes, though it's not standard of care. And multiple studies have found it to be safe and well tolerated, but long-term data are lacking. The problem is that different studies use different levels of carbohydrate. They could bring it down from 60 to 50%, 40%, all the way to ketogenic kind of a diet, which is less than 50, 20 grams. So it's very difficult to compare the outcomes of different studies. A systematic review of low carb showed that there was greatest improvements in glycemic control and greatest medication reduction with the lowest carbohydrate intake. So the lower you go, the better results you get. In keto diets, there's a transient increase in uric acid and blood urea nitrogen, not clinically significant. The bone mineral density unchanged after 2 years, so that concern is also out, but micronutrient deficiencies are seen. So coming back to my original slide of weight loss and improved glycemic control, you can see here that there is a comparison of the HbA1c as well as the weight with sleeve gastrectomy, gastric bypass, low calorie diets, and low carb diets. And you can see here, obviously, A1C comes down in all of them at 1 year, but starts to rise in all of them. And this mirrors what happens with the weight. But the best weight maintenance you can see here is with sleeve and bypass as compared to the low calorie diet as well as the low carb diet. But again, I caution you, interpretation of these studies is where you do not know, where you actually do know that it is not VLCDs that are used here, they're just low calorie diets. So it may be not really prudent to compare them because the direct trial has shown us otherwise. Now, this is an absolutely new meta-analysis that I'm going to show you. Diabetes remission in the Alliance of Randomized Trials of Medicine versus Metabolic Surgery in Type 2 Diabetes, or called the ARMS Type 2 Diabetes, where what they have done, they've clubbed together 4 different studies, including the Stampede of bariatric surgery, and they have a comparison arm with medical treatment. Again, caution, medical treatment here did not use VLCDs. So there were a total of 355 patients. They were into the parent trials actually. And so this is the flow chart of how they were randomized. So 121 to medical, 195 to surgical. There was some missing data. So at the end of it, you had 85% in the medical lifestyle who were analyzable and 171 in the surgical intervention that you can see here. So what you see here is the change in A1C from baseline 1 year, 2 years, and at 36 months. And you can see here that the different modalities that were used. Now, this was the gastric balloon, and these two together are the surgical arms, that's sleeve gastrectomy and gastric bypass, and this is the medical arm. So obviously, the surgical arm has done much better, both in terms of A1C as well as in terms of weight loss. And when it comes to therapy also, you can see that reduction in therapy is more with surgical than with medical. So this is what this actual meta-analysis tells you about the different 4 metabolic surgery that was done and compared to medical line of treatment, however, not VLCD, but a regular standard medical line of treatment. Now, the last part of my talk, a very important part, is about the RETUNE study. The RETUNE study was presented this year for the first time at the ADA 2022 by Roy Taylor, who went a step further and talked about trying to achieve remission in patients who were not so obese. If you recall, the direct trial was done in patients who had a BMI of more than 27. So in this study, what was done was patients with a BMI of less than 27, and if you look at the mean BMI here, it was 24.8, which is very, very similar to the BMIs that we see in India with type 2 diabetes. So this was the study that was done, and I had the fortune to have a discussion with Roy Taylor himself at the ADA, and this is the poster that was presented by him at the ADA, and this is the RETUNE study of remission of type 2 diabetes and weight loss in normal weight people or not so obese people. So weight loss induced remission has been used in studies that we know. It is now clear that etiology of type 2 diabetes concerns 4 major pathophysiologic factors: excessive liver fat, increased liver export of triglyceride, increased pancreatic fat, and suppression of beta cell function. But all the studies had people with BMI of more than 27. But there is a new hypothesis put forth by him, and that is the personal fat threshold, which means that 27 BMI does not really talk about a personal fat threshold. It is a population-based figure. So the personal fat threshold hypothesis postulated that thresholds for onset of type 2 diabetes depend upon degrees of susceptibility to the adverse metabolic effects. And so the aim was to test the personal fat threshold hypothesis by inducing stepwise weight loss in people who were not very obese with a BMI of less than 27. And what you see here is that the average BMI of patients here was 24.8. The 20 patients were studied, and there were 20 in the control group as well. Again, the duration of diabetes, of course, here was less than 6 years, and the A1C was around 7.1, and 10 patients were using metformin. Gliclazide was used by 2. So 2 cycles of 5% weight loss were used. Intra-organ fat, etc., was seen. Beta cell function was seen by the disposition index. And these were the results. What you find here is that sustained remission occurred in 70%, 14 out of 20. Median weight loss here was 6.4. It was not like 15 kgs or 10 kgs as you saw in the direct trial, because to start with, those people had a high BMI, and the thresholds for achieving A1C were as follows, as you can see here, and mean A1C decreased from 7.1 to 6.4. And it was concluded that the personal fat threshold concept explains why type 2 diabetes occurs in individuals of very different BMIs. So this answers the question of why Indian patients with lower BMIs get type 2 diabetes, because the thin fat Indian has a personal fat threshold, and therefore it is concluded that type 2 diabetes is a condition of homogeneous etiology occurring in heterogeneous individuals. It has been so nicely worded out here. And at 1 year, what they also saw was there was a weight loss generally of 9%, body fat reduced, liver fat reduced, triglycerides reduced, same as controls, and pancreatic fat also reduced but remained a little above that of controls. Insulin secretion increased, A1C of course came down, FPG came down. So what it means is that the etiology and pathogenesis of type 2 diabetes is the same whether you're obese or lean. So weight loss will be beneficial whether you're obese or lean. So lean is by BMI standards, but fat by fat threshold standards. So this supports the personal fat threshold theory, and therefore this supports the theory that weight loss is a therapeutic tool irrespective of whether a type 2 diabetes patient is obese or lean. Any amount of weight loss will be beneficial for glycemic control. So lastly, my views are that interventions aimed at reversal or remission are still not first-line standard of care therapy in any guidelines. But what we do know is that standard of care that is currently being advocated does not lead to reversal or remission. So it still remains optional. So the current standard of care may be suitable for some people, but there could be others who would surely choose a path of remission, and therefore the choice must be offered. Those who keep the weight off manage to keep the diabetes reversed. In the Indian scenario, even patients with longer duration on insulin therapy and or lower BMI can attempt reversal. I've already shown you the retune study, which tells you the same thing. And our own data at my center has shown that we are able to reverse diabetes in patients on insulin, in patients with lower BMIs, in patients with a duration of diabetes more than 6 years. The ones who regularly follow up are the ones who stay reversed, because it is very akin to, I'm going to show you cancer, where unless you monitor and make sure that their weight loss is maintained, there is no way that the diabetes is going to stay in remission. A 15 kg intentional loss might normalize life expectancy with type 2 diabetes. This is one of the most important slides that I could have shown you today, because ultimately you're talking about life expectancy. And you do know that life expectancy is reduced in type 2 diabetes for a variety of reasons. So if you want your diabetes patients to have a near normal life expectancy, you have to attempt weight loss, and that too substantial weight loss, because weight loss for type 2 diabetes is very, very akin to chemotherapy for cancer. And it follows the same. You have weight loss, you have a patient in remission, you follow up that patient regularly, make sure that the weight loss is retained. If there is a relapse, you again put the patient on a proper diet, again put the patient back in remission, and so on. And that is why it is likened to chemotherapy for cancer. So remission of diabetes that has been shown very robustly in several studies is a ray of hope for our patients. So the myths and the truths have been elucidated by me. At the end of the day, it is teamwork with the patient at the center. The only thing is that you have to find the right patient, do it at the right place and the right time, and you could be remitting your patients, giving them a better quality of life. So thank you all very much for your kind attention.
Thank you so much, Dr. Deshpande. It was a treat listening to you. We have been such big fans of your work in the field of diabetes remission, and thank you for the lovely presentation. So moving ahead, we would now invite another international speaker, Dr. Perele Adnam Hajj from Lebanon. She is going to brief us about the diabetes management in the elderly. Over to you, Dr. Hajj.
Good afternoon. Thank you for hosting me to talk about diabetes in elderly. I have nothing to disclose. And why diabetes in elderly? To start, aging population is a growing problem and important risk factor for chronic diseases like diabetes. Diabetes is highly prevalent in this aging population. Over 1/4 of people who have 65-year-old or above have diabetes, and half of patients 65-year-old or above have pre-diabetes, and the numbers are expected to increase rapidly in the coming decades. Many factors contribute to the high prevalence of diabetes in the elderly. To start with the genetic factors, they have impact on human longevity and predisposition to type 2 diabetes. You have also changes in glucose metabolism that are age-related, like the glucose-stimulated insulin response will be decreased in older patients. Insulin secretion pulsatility will also be decreased. Sensitivity to incretin will be decreased, and beta cell mass also will be decreased. We have also what we call the sarcopenia, where you have the loss of muscle mass and strength, which will increase fat mass infiltration, and this will worsen the insulin sensitivity. You have also in this population poor dietary habits and decreased physical activity, which will lead to reduced insulin sensitivity also. Add to this the polypharmacy and all the coexisting illnesses. So yes, we have to treat our older patients like our younger patients, but with special considerations. The special considerations here are geriatric syndromes, polypharmacy, and hypoglycemia. This is what I'm going to talk about. So what are the geriatric syndromes? These are various aging phenotypes that are independently associated with type 2 diabetes, like cognitive impairment and dementia, depression, frailty, disability, falls, and increase in urinary incontinence. And all of those geriatric syndromes will have a negative effect on the quality of life, functional outcomes, and mortality. What about hypoglycemia? We have clinical complications and comorbidities that increase hypoglycemia risk in this population, in this aging population with diabetes. You have the impaired cognitive function again. You have also reduced hepatic and renal function, which will lead to drug accumulation in the circulation, and this will lead to increased half-life of the drug in the circulation, and it will increase the risk of hypoglycemia. We have also, when you have hypoglycemia, you have the counter-regulatory hormones, the stress hormones like cortisol and glucagon that are secreted. Those also are slowed and altered in this population. And you have variable appetite and nutritional intake in this population. Our older patients can skip meals, they can forget to eat or eat multiple times. Add to this polypharmacy and slowed intestinal absorption that are additional risk factors of hypoglycemia. So there are some recommendations for diabetes in elderly, like you have to ask about hypoglycemic episodes at every time you have your patient, at every visit. Then you have to screen for geriatric syndromes, as they may affect diabetes self-management and diminish the quality of life. You have also to assess not only for the medical, but also for the psychological and functional, see if the patient has self-management abilities, yes or no, social and social domains, and this to provide a framework to determine targets and therapeutic approaches. What also is important is screening for cognitive impairment. Screening for early detection of mild cognitive impairment or dementia should be performed for adults who have 65-year-old or above at the initial visit, annually, and as appropriate. I don't know if we are doing this. This might be difficult. This might sound difficult to do in our clinics, but we have to pay attention to this. Why? Older adults with diabetes have higher incidences of all causes dementia, Alzheimer's disease, and vascular dementia. Poor glycemic control is associated with a decline in cognitive function, and longer duration of diabetes is associated with worsening cognitive function. Now, if preventing or delaying diabetes onset may help to maintain cognitive function in older adults, this is still questionable. We don't have studies. But intensive glycemic and blood pressure control have not demonstrated a reduction in brain function decline. So be gentle with your patients. Cognitive impairment makes it difficult for patients to perform complex self-care tasks such as monitoring glucose and adjusting insulin doses. It hinders their ability to appropriately maintain the timing of meals and content of the diet. So as I told you before, timing of meals, they can skip meals, and the content of diet, because they have the taste buds that are altered, they do want more sugary or salty food so they can be satisfied. So this is why the content of the diet will be altered. And it makes it challenging for clinicians to help their patients reach individualized glycemic, blood pressure, and lipid targets. When you have a patient that has cognitive impairment, you don't know what to do. You don't know how to set or reach the glycemic goal, blood pressure goal, and lipid targets. So to screen, you have assessment tools like Mini-Mental State Exam, Mini-Cog, and the Montreal Cognitive Assessment to identify patients requiring referral to a behavioral health provider for formal cognitive and neuropsychological care. So, if not screening at every visit, screen at least when a patient presents with a significant decline in clinical status due to increased problems with self-care activities. The patient who comes to you with errors in calculating insulin dose, difficulty counting his carbohydrates, who skips meals, who skips insulin doses, and difficulty recognizing, preventing, or treating hypoglycemia, you have to assess for his cognitive impairment. And then please go and simplify drug regimens and engage the appropriate support structure to assist the patient in all aspects of care. And when I say appropriate support structure, this could be a family member, a caregiver, or a chronic care center, etc. So what about a glycemic control? Is it the same for everyone? So in our older adults with diabetes, the aim of treatment is to the aim of treating them is to achieve comfort them, to give them optimal quality of life, and for the resolution of symptoms if they have hypo or hyper glycemia, and to avoid acute complications. In our younger patients, we avoid chronic complications, but what is very important in our older patients is avoiding acute complications like fall. Like if my patient is having hypoglycemia and he's going to get sugar to relieve his symptoms, he can fall. He can fracture his hip. So you have to avoid acute complications in those patients. And numerical targets are not as important as symptomatic well-being. So if you have a patient that is coming to the ER with severe hypoglycemia, with dementia and tachycardia, even if he has an HbA1c that is less than 7%, this is not good. This is the numerical target is achieved, but symptomatically your patient is not doing well. So don't forget that the elderly patients are a heterogeneous group. We have different types of elderly. You have the healthy elderly, the complex intermediate, and the very complex or poor health. The healthy ones have few coexisting chronic illnesses. They have intact cognitive and functional status. The intermediate complex group have multiple coexisting chronic illnesses. When I say multiple, I mean 3 or more coexisting chronic illnesses, or 2+ activities of daily living impairments, or mild to moderate cognitive impairment. For the poor health ones, those have end-stage chronic illnesses. They have stage 4, class 4 heart failure. They have end-stage kidney disease. They can be on dialysis. They can have end-stage cancer disease, or moderate to severe cognitive impairment, or 2+ activities of daily living impairment. And for those different types of elderly, you have different rationale. For the healthy ones, you have to expect longer remaining life. With the intermediate group, intermediate remaining life expectancy, and they have a high treatment burden, and they are vulnerable to hypoglycemia, and we have here to avoid fall risk. And for the poor health, the very complex ones, limited remaining life expectancy makes us think of the benefit of treatment. So benefit of treatment is uncertain here. So my healthy patient has a different reasonable A1C goal than a complex intermediate one than a very complex or poor health one. So for a healthy older adult with diabetes, go for a goal of A1C below 7 to 7.5%. I personally can go even less than this, to less than 6.5% if my patient is really healthy and I can achieve this without a risk of hypoglycemia or without side effect. This is because in this way, I can be preventing problems in these patients like microvascular and macrovascular complications. And this is still very important in the older adults, especially if he is healthy. So another goal for the intermediate complex ones is less, so please, less tight, less than 8% A1C goal. And for the poor health, just avoid reliance on A1C. Just the glucose control decisions should be based on avoiding hypoglycemia and symptomatic hyperglycemia. So for my different patients, I have different fasting and bedtime glucose goals. The healthy ones, the fasting can be 80 to 130 for the healthy ones, 90 to 150 in the intermediate, and 100 to 180 in the very complex one. And for the bedtime glucose, it can go for the very complex patient up to 200 milligrams, not below 110, please, just to avoid, again, hypoglycemia. What's beyond glycemic control? What about treating hypertension? Do we have evidence on treating blood pressure in those patients, in those elderly diabetic patients? Yes, we have strong evidence from clinical trials of the value of treating hypertension in older adults with treatment of hypertension to individualize target levels. Like for my healthy and complex intermediate patients, I should go below 140 over 90 millimeters Hg, and in complex or poor health patients, go below 150 over 90 millimeters Hg. So what about other cardiovascular risk factors? Of course, in all patients, just encourage stopping smoking. And for the lipid-lowering therapy and aspirin therapy, it may benefit those with a life expectancy that are long enough to real benefit. So in the studies, in the primary and secondary intervention trials, in those elderly patients, we found that these are 2 to 6 years. So we can find benefit 2 to 6 years if we are treating them. So in healthy and complex intermediate patients, yes, you can consider statins unless it's not tolerated. But for more complex and poor health patients, consider the likelihood of benefit with statin. For myself, personally, I do not use statins for those patients. What about the lifestyle management? So diabetes in the aging population is associated with reduced muscle strength, poor muscle quality, and accelerated loss of muscle mass, which may result in sarcopenia and or osteopenia, like we already said. So diabetes is also recognized as an independent risk factor for frailty, which is characterized by decline in physical performance and an increased risk of poor health outcomes. Inadequate nutritional intake, particularly inadequate protein intake, can increase the risk of sarcopenia and frailty in older patients. This is why the life management in older adults should be tailored to frailty status. For all of them, encourage optimal nutrition and protein intake. And for those who can safely engage in activities like regular exercise, like aerobic activity, weight-bearing exercise, and or resistant training, go ahead. If they can safely engage for such activities, go ahead and encourage them to do this. And for older adults with type 2 diabetes, and they are overweight or obese, and their capacity to safely exercise, they have the capacity to safely exercise, go for even an intensive lifestyle intervention, like dietary changes, physical activity, and modest weight loss from 5 to 7% initial weight, because this has proven to be beneficial on quality of life, mobility, and physical functioning, and cardiometabolic risk factor control. So we come to the pharmacological therapy. Medication classes with low risk of hypoglycemia are definitely preferred in this elderly population, because overtreatment of diabetes is common in older adults and should be avoided. Go for simplification of complex regimens to reduce the risk of hypoglycemia and polypharmacy if it can be achieved within the A1C target. And of course, consider costs of care and insurance coverage rules because this will reduce the risk of cost-related non-adherence. Metformin is the first-line agent for older adults with type 2 diabetes, as it is for younger adults also. It may be used safely in patients with eGFR more than 30 milliliters per minute. It is contraindicated in patients with advanced renal insufficiency, and we have to use it with caution in patients with impaired hepatic function or heart failure because of increased risk of lactic acidosis, as you already know. Metformin may be temporarily discontinued before procedures, during hospitalizations, and when acute illness may compromise renal or liver function. What I mean by this is even patients at their home, when they have diarrhea or vomiting, they have gastroenteritis, for example, you can discontinue metformin or encourage to discontinue metformin because a dehydrated patient may have a high creatinine with compromised renal activity, and this will put your patient at an increased risk of lactic acidosis. Metformin can cause GI side effects and a reduction in appetite that can be problematic for some older adults. So if it is the side effect of metformin, the GI side effect is pronounced in your patients, you have to stop it. For those taking metformin for long term, monitor for vitamin B12 deficiency. Thiazolidine have to be used very cautiously in those patients on insulin therapy, as well as those patients with or at risk for heart failure, osteoporosis, falls or fractures, and or macular edema. And lower doses of TZD in combination with therapy may mitigate these side effects. For the insulin secretagogues like sulfonylureas, They are associated with hypoglycemia, as you know, and could be used with caution. Caution, especially with elderly who forget or skip meals. Caution, especially also when drug-induced hypoglycemia, because drug-induced hypoglycemia is very common with renal and cardiac dysfunction and gastroparesis. What about the incretin-based therapies? You have the DPP4 inhibitors, the dipeptidyl peptidase 4 inhibitors. They have few side effects, minimal risk of hypoglycemia. They are very safe. The reduction in HbA1c is very efficient. It's similar to younger patients. They are weight neutral. You have the only side effect is their cost. That may be a barrier to some older patients. The other incretin-based therapies are GLP-1 receptor agonists. They showed the cardiovascular benefits among patients with established and those at risk of atherosclerotic cardiovascular disease. They showed to reduce major adverse cardiovascular events, cardiovascular death, stroke, and MI to the same degree for patients above and below 65 years of age. The problem with the GLP-1 analogs is that they are injectable, except for the oral semaglutide. We do not have it here in the balloon. And injectable agents require visual, motor, and cognitive skills for appropriate administration. We have agents with a weekly dosing schedule that may reduce the burden of administration. You can use it with the elderly safely. And the only side effect, or the most common side effect, is the GI side effect in those agents, like nausea, vomiting, and diarrhea. And they can be pronounced in some patients. So don't give it if they cannot bear it. And it may not be preferred in older patients who are experiencing unexplained weight loss, of course. What about the sodium glucose co-transporter inhibitors, the SGLT2 inhibitors? Patients with established atherosclerotic cardiovascular disease, in those patients, these agents have shown cardiovascular benefits, and also they showed beneficial effect for patients with heart failure and beneficial effect on slowing the progression of chronic disease. Older patients have similar or greater benefits than younger patients. So these are as good as for young patients and adult patients. But keep in mind that we have the side effect of those agents, like volume depletion, urinary tract infection, and worsening of urinary incontinence that may be more common among older patients, and they can be sometimes problematic. So you have to search for the side effect or ask for them, assess for side effect each time you have the patient at clinic. What about the insulin therapy? Insulin therapy in those patients requires that the patients or their caregivers have good visual and motor skills and cognitive ability. So insulin doses should be titrated to meet individualized glycemic targets and to avoid hypoglycemia. A once daily basal insulin injection therapy is associated with minimal side effects and may be a reasonable option in many older patients. When choosing a basal insulin, long-acting insulin analogs have been found to be associated with a lower risk of hypoglycemia compared with NPH insulin. Multiple daily injections of insulin may be too complex for the older patient with advanced diabetes complications, life-limiting coexisting chronic illnesses, or limited functional status. For this, you have the ADA, the American Diabetes Association, gave us a simplification of a complex insulin therapy where patient on basal or prandial insulin, where patient on basal insulin, you go and change the timing from bedtime to morning, and prandial insulin, you decrease the dose. And if the insulin dose is less than 10 units per dose, you discontinue the prandial insulin and add non-insulin agent when there is a possibility for this. So I will not go through all of this slide, but you can have it and you can go back to it when you have to simplify a complex insulin regimen. With this, I come to my conclusion. Many factors contribute to the high prevalence of diabetes in the elderly. Older adults are a very heterogeneous group, which requires individualization of treatment goals. And treatment goals are the same as those for younger adults, but with special considerations regarding geriatric syndromes and hypoglycemia. And for the lifestyle management, you have to take care of nutrition and exercise whenever those patients can do exercises. And for the pharmacotherapy, go for simplification of the treatment. Simplification of the treatment is the key. And to care for those who once cared for us is one of the highest honors. These are my references, and with this, I thank you for listening. Thank you.
Thank you so much, Dr. Hajj, for such an insightful presentation. And with this, we close for today's presentations. We will now take some question and answers from our audience. My first set of questions are for Dr. Ming Yeong. Ma'am, my first question for you is, do you believe that there's a lack on the part of the doctors or diabetes educators for educating their patients on self-management of diabetes? Kindly share your 2 cents on counseling these patients.
Okay, I think it's very important. Everyone with diabetes should be offered this DSMES. First thing, before we offer, they have to believe that it will help them in their life living with diabetes, because one of the most important things of diabetes management is prevention of complication, because that is costly and it reduces quality of life. So from all of us, from the healthcare providers, we have to take this effort to overcome this barrier of referral to diabetes, patient to diabetes education, and try to explain to the patient why they need it. And from the aspect of diabetes, from the aspect of the medical practitioner, from the aspect of we as diabetes educator, we have to make sure we meet the people's need when they are being referred to us.
Thank you so much, ma'am. Moving ahead to my next question. How can we ensure that the patients have gained knowledge about self-education correctly and that they are implementing this knowledge in their day-to-day life?
Thank you for the question. Very important. Usually, the diabetes education session is not one session. So on every follow-up session, we'll need to recap what the patient has learned. This is where we know whether they have changed. Because diabetes education is not knowledge, it's not skill, but a change of behavior based on the AADE7 self-care. If they can't, they have problems, they have challenges changing, then we have to reset our goal. If they are able to change their self-care practices, then we can move on. Remember, there are 7 self-care practices. Then we do not straight away ask them to change all the 7 self-care practices, but 1 at a time, or 1 and 2 at a time. So at every follow-up, we reassess them.
Thank you so much, ma'am. Now moving to my last question for today. Can the monitoring of effectiveness of DSME be done with the help of technology? and where the patient as well as the doctor gets a real-time update about the patient's glucose level?
Yes, definitely. This is what I call moving forward with DSMES. Technology has helped us to reach a wider field of patients, especially the younger patient. And because we engage them in their self, in empowering them to look at, to monitor their own blood sugar, then they will feel empowered, they'll feel engaged, empowered. On our part, we need to provide the feedback as soon as possible, because it's no point to provide feedback if they send you the blood glucose result the last a month ago. With that, then only as one of the characteristic of efficacy, self-management education is two-way communication. I strongly agree with that. Technology has actually helped us, and especially the new technology like continuous glucose monitoring, continuous blood pressure, mainly the blood glucose monitoring, not so much of the continuous blood pressure monitoring, the one that can just do maybe twice a week. And that also helps us to understand better the life of people with diabetes, their blood glucose profile, so that we can be more precise in our adjustment of medication. Thank you.
Thank you so much, Dr. Tan, for such lovely answers. Moving ahead to Dr. Neeta Deshpande. Ma'am, my first question for you is, what is your expert opinion on metabolic surgeries for remission of diabetes?
Yeah, so metabolic surgery has been known to remit diabetes from a very long time, and there are different mechanisms that have been postulated to explain how that happens. One is, of course, the weight loss, but even before the weight loss, there is remission of diabetes, and it is because of the GI hormones that change in concentration. And definitely metabolic surgery is one of the modalities of treatment. But as of today, it is not being used really for people with lower BMIs. So it still remains a treatment of choice with people who have, a high BMI, and their remission of diabetes happens. But please remember that weight regain after metabolic surgery also can bring the diabetes back. So in any case, maintenance of the weight that has been lost is the key.
Thank you so much, ma'am. Moving ahead, since you already mentioned that the greatest challenge to sustaining type 2 diabetes remission is maintaining of weight loss and lifestyle change. So how should patients try to maintain the weight loss and lifestyle change?
Right. So there are 2 or 3 different things out here. Number one is that follow-up is extremely essential. See, if a person starts to regain weight, it's easier to bring the patient back when he has just put on 2 or 3 kgs rather than when he has put on 10 kgs, obviously. Even in the direct trial and even in some of the other studies, we do what is called as a rescue diet. So somebody has started to put on a little more weight, we again bring them back on a very low calorie diet, give a rescue diet and bring them back in remission. Having said that, for long-term remission, 2 things are very important. One is a regular exercise regimen. As in every case of obesity where weight loss has happened, exercise becomes extremely important to sustain that weight loss. And even in the exercise, muscle training, strength training is extremely important. So apart from the cardio training, strength training is very important to preserve muscle mass, because preservation of muscle mass is again very important for diabetes remission. So exercise to be increased. And lastly, the protein intake. The protein intake has to be adequate. I'm not talking about a very high protein diet, but a well-maintained protein diet, or what is required, what is recommended, has to be given to the patient. And this is how weight loss can be maintained.
Thank you, ma'am. Moving to my last question. So should a continuous glucose monitoring be used by a patient who is in remission to keep a check on his current sugar levels?
Yes, actually, it's a very good tool to train the patient as to what is happening with different kinds of food, especially if a CGM can be used. And perhaps if a CGM is used, a person will come to know about a relapse much earlier than just going and doing levels of HbA1c and fasting and PP sugar. So a CGM might really be very, very useful, and that is something that has to be explored in the future in patients who go into remission, maybe at specific intervals after remission. A person can apply a CGM on and off and figure out what's happening with the sugar. So that's a great tool to aid in early diagnosis of a relapse.
Thank you so much, Dr. Deshpande. My last set of questions from Dr. Hajj. Ma'am, my first question for you is, in elderly with risks like cognitive dysfunction, depression, or functional disabilities, how should the patient perform diabetes self-care?
When you have a cognitive disability that is mild to moderate or moderate to severe, you have to be either, you have to have a caregiver, a family member that is coming with your patient, so you can talk to him and rely on him to give care to your patient. And in severe cases, I guess you have either the caregiver, family member, or a chronic care center for those patients.
Thank you, ma'am. My next question is, how important of a role is of the family or the caregiver in treating elderly patients with diabetes? And how should the physicians counsel the family members to keep the patient's glucose level within the range?
So you have to set goals with the family members. So you have to individualize your patient. Like I said, if this patient is a healthy patient, you have to talk to him and set goal for either glycemia and everything, the A1C, lipid target, blood pressure target, and you have to talk to the caregiver if the patient is unable to do it with you. And in this case, you have to simplify, in all cases, go and simplify the goals, the treatment regimen, and of course, treating elderly patients is not as simple as treating younger adults, because they have to rely on someone, and this someone have to be educated. And education, maybe in our countries, is difficult to do. We don't have support programs, or but in many other countries, you do have those support programs. You do have diabetes education in the hospitals and the chronic care centers, etc. But yes, of course, I agree with you. This is not simple. This is not easy.
Thank you, ma'am. Last question. What is your best practice to avoid polypharmacy and medication non-compliance?
Again, you have to simplify. You have to think your patient is an 80-year-old patient that has chronic kidney failure with he is bedridden. Is it really necessary to give him statin? Is it really necessary to have a blood sugar that is below 100, or do we have to panic if my patient has an HbA1c of 8%? So individualize your patient, and this is the key. This is the key, Darshika.
Thank you so much, Dr. Hajj. And thank you. This brings us to the end of our first session today. Thank you so much, Dr. Tan, Dr. Hajj, and Dr. Deshpande, for your time and efforts you took to share your thoughts and experiences with the Docplexus community on this occasion of World Diabetes Day. A big thank you to our dear audience for their kind listening, hoping this session would give you new insights in the treatment of diabetes with a global perspective. Stay tuned for our upcoming session on holistic management of diabetes today evening, 6 p.m. And with this, we close today's talk. I would see you all very, very soon. And until then, please stay safe, stay updated, take care, and a happy Docplexing.